Hello everyone. So welcome to another short session uh, where we are going to discover medicine newly again. And first of all, whoever is watching the video now, I am really thankful to you for making it here in a short notice. Um, well, this is again going to be a short presentation where one of the things that I discovered newly that I'll be sharing with you. The concept of the whole video is simple. Like, I'm reading something and I discovered something newly, which I am sharing with you, and this, if it's valuable, you can take it and apply it in your clinical practice or taking it forward for just enriching your knowledge. So today's topic, first thing about this topic is um, the discovery happened recently when I was on stage presenting something, and some of the things were new for me when I was preparing, but some discoveries happened on the stage, like when presenting, and some questions were asked, and I started answering them. And you'll also come across experience like this when someone asks you a question and you are answering something. Slowly, a point flashes like, oh, this I can explain it this way also, right? So that experience happened to me also, and my intention is whatever you read, see that you are communicating to some of your friends, or if someone asks a question, make an attempt to explain to them so that the knowledge that you have expands, and also makes a difference to the other person who is listening to you. Okay, so today's topic, let's get into the topic now straight. I will start sharing the screen now. Well, the topic is titled Discovering the Reaction in Reactive Arthritis. First thing is, I want to introduce you to a concept called black box analogy. Okay, so like, what is this black box? Many of you might have heard that black box is a recorder placed inside the plane in the cockpit. So if in event of crash or anything, you will get last minute evidences to find like what actually happened, right? But there is another black box, another idea which also use the same term called black box, where what happens is like, the stimulus or the input, and you also know what happens after that output or the response. For example, if you are watching television and you use the remote, like this input of pressing the power button on switches the TV on, right? And you get a screen on which you can see pictures and videos, right? Now the input is pressing the button, and the output is the visual, things that is showing up on the screen. But most of you will not be aware like what happens inside the television, right? And that is called as a black box. And given the topic today, reactive arthritis, so there are many joint conditions where the actual thing, the input to the body that is happening is inflammation, no, and the output, the way you're going to handle that patient is by giving immunosuppression, right? And your knowledge lies inside the black box. you know if you look currently, if you look consider currently the evidence of COVID disease or coronavirus treatment. Many people know that, okay, there is inflammation and we are going to use steroids and other immunosuppressants, right? But there is a joke which runs around like, quacks have been practicing with steroids for so many years, but the difference that is there between the quack and you would be your knowledge beneath this black box, which is hidden inside the black box. Okay, so what we're going to do today is, there are many joint conditions where the condition is caused because of inflammation, like the inflammatory signs like rubor, tumor, dollar, calor, functional assay, right? Rubor for red, tumor for warmth, calor for tumor for swelling, calor for warmth, dollar for pain, functional assays for loss of function. Okay, this is what happens in a joint. And you also know the treatment is suppressing immunity with non-steroidal agents, NSAIDs, or steroids or other suppressants, right? So in all the joint conditions, today we are going to distinguish reactive arthritis. So we are going to now decode the black box specifically in relationship to reactive arthritis. First of all, reactive arthritis was also called as Reiter syndrome. Okay, it was named after a scientist called Reiter, but later the name got changed because during the World War times, he was known to take part as a German camp in human experiments that were considered inhuman. Slowly, so the name has lost its importance, but it may somewhere show up as a question, Ritter's triad, or what was the former name, anything like that. So just for you to know that, So currently, the name that is popular and recommended to use is only reactive arthritis. Okay, and okay, I'm going to give you 30 seconds. If you can make a pen and a paper arrangement or a book and a pen arrangement, please have that. The whole of reactive arthritis, I have condensed it into 10 points. Okay, and if you can note them down, it will be a together we just finished off this topic. So I'll give 30 seconds for that. Meanwhile, I will slowly explain. So by the time you join, we will not be staying quiet for that time. So reactive arthritis, the first thing is it is acute non-purulent arthritis. So you would have heard this thing. Oh, it's a reactive response of the body. Like what it actually means, literally means, is there is an infection in the body, and the body reacts to it. And in this reaction, there is arthritis happening. So here, the infection is not causing the damage. It is the body's reaction that is causing arthritis, right? And when it says acute non-purulent arthritis, the purulent would be a bacterial infection, right? Or an infection with infecting pathogen directly in the joint. So this is acute non-purulent arthritis because there is no direct infection, at least as a obvious cause for arthritis. Next point is it follows commonly gram-negative bacterial infections, and most commonly they are enteric or gastrointestinal than urogenital infections. Okay, and the common organisms that causes gastrointestinal you must be knowing, like Salmonella, Shigella, Campylobacter, and the urogenital Chlamydia and Mycoplasma. Okay, these are the common and popular organisms that are spoken when it comes to reactive arthritis. And there is a classic triad. It's not again, it is not like this is the criteria to diagnose, but this was a classical triad which was seen in the past, where arthritis, urethritis, and conjunctivitis were making the components of this triad. Um, well, again, there are many other manifestations that can happen other than this triad. This currently, this remains just as a popular classical triad as an academical purpose only. For if you want to apply it clinically, you don't have to stick to only the triad. And this is something which may come handy. The most common age range is between 18 to 40 years. And HLA-B27, as with many arthritis conditions, when it is positive, you may get a severe and a chronic form. Okay, and amongst these, one thing that I want to say is, see the infections that are there, it follows an infection, but the joint is not infected. This needs to really get in. It has to be like, okay, after this session, I remember that there is an infection, but joint is not direct infection. Okay, which is not obvious. There is no pus when you drain the, like if you are doing a joint aspiration, you will not find a pus. If you find a pus, it cannot be reactive arthritis. Now I've made it a little simple again. The sixth point, if you look, all are A. If someone asks you to describe how, what are the features of arthritis, reactive arthritis, you can use this line. It is acute arthritis. The onset will be of acute in origin. It is asymmetric, like right ankle is involved, left ankle may not be involved. There are other conditions symmetric. Today we are limiting the discussion to only reactive arthritis. So it is asymmetric and it is additive. So you had pain in right ankle, then you will have left ankle, then you will have right knee, then you may have left knee. Here if you see, it doesn't mean that after the pain, transfer, like once the pain was in right ankle, then you have pain in left ankle, the right ankle pain doesn't disappear. There are other conditions called migratory polyarthritis where the joint pain will disappear from one joint before appearing on the other joint. Okay, here that doesn't happen. Here the number of joints involved with pain just add up, additive, and antecedent infection within last 1 month. Okay, so these are the all A's, that will give a classical description of reactive arthritis. So first discovery that happened to me on stage was, uh, in the case that I was presenting. What happened is the patient was having fever even now. Okay, and this says in reactive arthritis it is antecedent infection less than 4 weeks. Okay, so first thing I told, what I discovered is what they're saying is antecedent infection. They're not saying antecedent fever. So it is possible that in reactive arthritis patients can have fever. And the next thing is the infection has to occur before 1 month, before uh, like within last 4 weeks or within last 1 month. But that doesn't mean that infection must have been cleared from the body. So the patient can have a infection still persistent in the body, like a septicemia, but the joint may remain clear and he may complain of pain. And still in that condition, you will call it as reactive arthritis. So if you are doing a blood culture, you may find an organism like we found for that patient, E. coli, Escherichia coli. So that patient still has reactive arthritis. So it doesn't mean that infection should not be there in the body. The infection can be thriving inside the body. It is only the joint space which is not infected, but there is pain. And as I said, there are many other manifestations other than the triad. Out of that, one rare manifestation is myelitis. Well, our patient had this. That's why I have just kept it there. It is not only limited to joints. So if you are seeing a patient who has some neurological signs, plantar reflex upgoing, you can still continue to make the diagnosis of reactive arthritis. Well, the treatment again, so as without the knowledge, you can say is NSAIDs, steroids, and other immunosuppressants. Obviously, it's an inflammatory pain, so this will work. Next thing is the role of antibiotics. Well, the whole matter for you to diagnose reactive arthritis is to find out whether to consider antibiotics or not. If it is acute arthritis, the antibiotic usage is still controversial. In our patient, when we had blood culture showing Escherichia coli, we continued with antibiotics. But if there was no infection in blood, still should we consider antibiotic or not? That is still controversial, and that has to be that judgment has to be made by you based on case to case. Okay, and in chronic arthritis, definitely they have tried antibiotics for good response. Where they're using antibiotics, you can take the screenshot of this if you need. I'm going to read that out. 6 months of rifampicin and 5 days of azithromycin. This is one combination. Or 6 months of rifampin and doxycycline. The dosages are there in the brackets. I will not be using much time for dosages now. Okay. So really, let's look at what is the reaction that is happening inside the body. Well, the organisms that I told you, whether it is Salmonella, Shigella, Escherichia coli, Chlamydia, Mycoplasma, all those things, they cannot point out, okay, this is what is happening inside the body. The logic again I told you is infection happened, the body responds, and that response is causing joint pain. That is clear. But why the joints are involved in particular pattern? Why the joint is involved? Why the pain and damage happens in joints? Well, this is one theory which I found. So consider any of the infection, any of the agent causing this infection. They have this property to invade tissue and survive intracellularly. Okay, so you may not find a infection in the joint space, but the synovial lining, when they have cultured them, they have many times found those organisms which are surviving intracellularly. Okay, the other mechanism is molecular mimicry, but this is something which will also give a knowledge about why particular joints. So this may be an add-on explanation. And what will happen for this? When these agents are surviving intracellularly, there is immune activation against persistent antigens. Again, you need to focus on the word survive, and also you can look at the persistent antigens. And this persistent antigens and the response to it will cause damage. That is called as reactive arthritis. And one more thing that I wanted to share is, I was thinking like, can uh, infection go, like, is it not necessary that body is to react and there should be no infection? What helped me find an answer in that is one of the standard book mentions that human immunovirus HIV, its classical presentation is influenza-like illness. The first presentation could be like a flu-like illness or an influenza-like illness, right? But I would take that back. The first response could be like a flu-like illness. I will take that influenza-like illness part. It is not. Okay. So the flu-like illness may be the first presentation of HIV, right? But it also said in some cases, the first representation or first presentation of the HIV infection could be reactive arthritis. So the logic is still there, right? How can HIV infect a person and he develops reactive arthritis, and by that time HIV virus is cleared off the blood? It is not possible. So this gives you an answer that infection need not be contained, or infection need not be absent when there is reactive arthritis. So for a patient with reactive arthritis, it is possible to continue to have infections. And if you find an evidence, strong evidence, in acute arthritis, reactive arthritis, you can still consider antibiotics. Going ahead with only immunosuppression without antibiotics may worsen the condition. Well, this is one of the manifestations which can be seen, cutaneous manifestation. See, one of the things they are causing is in the triad, you saw mucosal involvement. So they can cause genital lesions and as well as lesions over skin. This is a lesion called as keratoderma blennorrhegica, which contains multiple vesicles, and papules, predominantly on palms and soles. So out of this image, I want you to remember palms and soles, but they can also be seen in other areas of skin also. Yeah. So this is one. Again, I hope this short presentation helped you add a knowledge at a faster pace. So if you're liking this work, kindly subscribe to the channel, and we will discover medicine together in future. And if it has still not motivated you to subscribe to the channel, I'll make my next attempt very soon. Thank you for that. And if you have any feedback, if you need any more topics, any questions you have, you can drop them in the comment section. And if you have any questions, see, there is a lag in the video. So on this current platform, YouTube channel. So if you have a question, I recommend you start typing as soon as you find the questions, so that when I finish the presentation, you may not find time to type them. Okay, so I will now stop sharing the screen. If there is a question, I will take them. Otherwise, we will end the discussion. And if you have a question, and I am ending the presentation, then please you can forward the question in the comment section also. I will definitely answer it there. Okay. So, thank you for giving me this opportunity. I hope this session was useful to you, and you will definitely take it forward in making a difference to the patients who are coming to you with joint pains. Okay. So take care. Bye. Meet you soon with the next session.